Right now, before you do anything else, I want you to hold up one of your hands and look at the base of your thumbnail. Not a glance, a real look. Because in the next few minutes, I am going to show you something that most people over 60 have never been told. That small white crescent at the base of your nail is called the lunula. It has been sitting there your entire life. And if you know what it means when it begins to change, it can warn you about 5 serious conditions, each one carrying cardiovascular consequences that most patients are never given the chance to act on. I am Dr. Arthur White, and I have dedicated most of my career to preventative cardiovascular care for adults over 60. Over the years, I have seen something in my clinic that genuinely bothers me. The warning was already there on their hands, months before anything dramatic happened. Nobody had noticed. Nobody had explained what to look for. Stay with me until the very end, because the 5th condition is the one that surprises my patients most. And it involves a medication that millions of older adults take every single day. Type your age in the comments right now and tell me whether you currently take a proton pump inhibitor or metformin. Look at the base of your thumbnail right now, not a glance, a real look. Find that small whitish crescent sitting just above the cuticle. That shape is called the lunula. You have looked at it thousands of times without knowing its name, and almost certainly without knowing what it means when it starts to change. Before we go any further, I want you to type something in the comments right now. Tell me your age and whether you currently take a proton pump inhibitor or metformin. Your answer is going to determine how urgently you need to pay attention to everything we are about to cover. I am Dr. Arthur White, and I have dedicated most of my career to preventative cardiovascular care for adults over 60. Over the years, I have seen something in my clinic that genuinely bothers me. Patients come in after a cardiac event, a heart attack, a diagnosis of heart failure, a stroke, and when I look carefully at their hands, the signal was already there, sitting at the base of their nails, shrinking quietly for months, sometimes for years, before anything dramatic happened. Nobody had noticed. Nobody had explained to them what to look for. That ends today. Stay with me until the very end, because the 5th condition I cover is the one that surprises most of my patients. And it involves something millions of people over 60 do every single day without understanding the consequence. To understand why the lunula carries this information, you need a small piece of biology. The lunula is the only portion of your nail matrix visible to the naked eye without any instrument. The nail matrix is the actively dividing tissue just beneath the base of your nail, the zone where new nail cells are produced around the clock. The lunula appears white rather than pink for one specific reason. The dividing cells in that region are packed densely enough to obscure the capillary bed beneath them. It is that density of living, actively dividing cells that gives the lunula its color and its crisp, visible border. When the lunula begins to shrink, blur, or disappear entirely, a condition called aplasia of the lunula, it means the nail matrix is no longer receiving sufficient blood supply, sufficient nutrients, or sufficient cellular energy to maintain that density. The whiteness fades because the cells are fewer. The border blurs because the matrix is thinning. This is not a cosmetic variation. It is a physiological signal that something systemic is reducing your body's capacity to sustain one of its most metabolically active tissues. The reason this matters particularly after 60 is the same reason most cardiovascular warning signs matter more after 60. Your body's capacity to compensate quietly for early dysfunction narrows with age. In your 40s, the nail matrix can lose some of its nutrient supply and adapt without any visible change at the surface. After 60, those reserves are thinner. The compensation is shorter. The signal appears earlier, and your lunula is often where it appears first. The problem is that a standard clinical appointment rarely includes careful examination of the lunula unless something is visually alarming. The research connecting lunula changes to systemic disease exists in the medical literature. It simply does not travel from that literature to the person sitting at home who actually needs it. That gap is exactly what I want to close for you today. The first condition I want to walk you through is iron deficiency anemia. Iron does something in your body that most people are never taught. It is not only the raw material your red blood cells use to carry oxygen, though that role alone is critical. Iron is also required for the function of an enzyme called ribonucleotide reductase, which drives DNA synthesis in cells that are actively dividing. And the nail matrix divides faster than almost any other tissue in the body. When your ferritin levels begin to fall, ferritin being the stored form of iron your tissues draw from, the nail matrix is among the first tissues to be metabolically rationed. Cell division in the matrix slows, the density of actively dividing cells decreases, and the lunula, which depends on that density for its visibility, begins to shrink and lose its sharp border before it fades entirely. What makes this clinically important is the timing. A 2050 study in the International Journal of Dermatology confirmed that lunula changes, reduction in size and loss of definition, were among the earliest observable physical signs of iron deficiency in adult patients. They appeared at ferritin levels that most routine blood panels would not yet flag as critically low. That is not a minor detail. It means the signal on the nail arrived before the laboratory result crossed the threshold that typically triggers a phone call from your doctor's office. A patient I will call Frances came to see me at 67. She had no dramatic complaints. She was a little more tired than usual, which she attributed without much thought to her age. During the exam, I noticed that the lunula on her thumb and index finger had become indistinct. Not gone entirely, but blurred. The border no longer crisp. I asked her careful questions, ordered a full iron panel, and found ferritin levels low enough to explain the nail change, but not yet low enough to appear alarming on a standard result summary. We addressed the deficiency early. Frances is doing well today. Her lunula has a visible border again. Her nails were the doorway that opened that conversation before her body had to compensate any harder than it already was. The cardiovascular consequence of iron deficiency anemia is direct and serious. An iron-depleted heart cannot rely on its red blood cells to carry adequate oxygen per unit of blood. To compensate, it increases both its rate and its stroke volume. It beats faster and pushes harder with every contraction. In a younger heart with full reserves, that compensation is sustainable for a long time. In an adult over 60, with any existing degree of cardiac dysfunction, sustained compensatory overwork accelerates the progression of that dysfunction and significantly increases the risk of heart failure. The lunula was recording the depletion. Frances's nails were asking for help months before any other sign made the request audible. The second condition is hypothyroidism, a deficiency of thyroid hormones T3 and T4, and it affects the lunula through a mechanism that is straightforward once you understand it. Thyroid hormones regulate the metabolic rate of every cell in the body. When those levels fall, every cell slows down the keratinocytes in the nail matrix responsible for continuous division. As division slows, the matrix thins. The lunula shrinks and fades. The nails themselves grow more slowly, become brittle, develop fine longitudinal ridges along their surface, and lose their natural gloss. Each of changes arrives so gradually that most people adjust to them one by one without ever recognizing the cumulative picture they are assembling. That gradual onset is precisely why hypothyroidism is one of the most underdiagnosed chronic conditions in adults over 60. An estimated 10 to 20% of adults in this age group are affected. The fatigue comes on slowly. The cold sensitivity increases by degrees. The weight changes are modest at first. Each symptom is gentle enough to be explained away. Age, a difficult season, not sleeping well, and by the time the full picture becomes undeniable, the condition has often been quietly progressing for years. The lunula, thinning across those same years, was signaling something the rest of the symptom picture had not yet made obvious. The cardiovascular implications are severe and specific. Low thyroid hormone impairs the expression of LDL receptors in the liver, so the liver cannot clear LDL cholesterol from the bloodstream efficiently. LDL rises. Systemic vascular resistance increases, pushing diastolic blood pressure upward. Heart rate variability, one of the most reliable markers of cardiac autonomic health, decreases. Coronary atherosclerosis accelerates. A 2019 meta-analysis published in the journal Thyroid found that even subclinical hypothyroidism, borderline low thyroid function with few obvious symptoms, was associated with a 20% increase in coronary heart disease events and a 39% increase in cardiovascular mortality in adults over 65. That is not a marginal statistical footnote. It is a major signal, and it is almost entirely preventable once the diagnosis is established and thyroid replacement therapy begins. A patient I will call Raymond came to see me at 72. He had a modest complaint. He had noticed he was trimming his nails far less often than he used to, and he mentioned it almost as an aside. During the exam, I noticed the lunula on his thumb was barely visible, its border indistinct. After a full thyroid panel and a careful review of his cardiovascular risk profile, we identified subclinical hypothyroidism that appeared to have been present and unaddressed for several years. Raymond is on appropriate therapy now. His nail growth has normalized. His LDL has come down without any change to his diet. His nails had been recording the slowdown. Long before his symptoms assembled themselves into a picture anyone had thought to investigate. The third condition is one that receives far less attention in conversations about cardiovascular risk in older adults than it deserves. It is protein energy malnutrition and low blood albumin, a state called hypoalbuminemia. Albumin is the primary transport protein in your bloodstream. It carries hormones, medications, and nutrients to the tissues that need them, and it performs a structural function that is easy to underestimate. It maintains oncotic pressure, the internal force that keeps fluid inside your blood vessels rather than allowing it to leak into surrounding tissues. When albumin falls, that force weakens, and the nail matrix, which depends on albumin as the protein substrate for keratin synthesis, begins to lose the raw material it requires to sustain cell division. The lunula shrinks. In significant deficiency, it disappears entirely. I want to pause here on something important. Low albumin is the same underlying mechanism that produces Muirche's lines, those horizontal white bands running across the nail surface that are associated with heart failure and nephrotic syndrome. What this means in practice is that a disappearing lunula and Muirche's lines can appear on the same pair of hands at the same time. Two different nail signs, both visible in ordinary daylight, both reflecting the same nutritional and circulatory compromise from two different surfaces of the nail simultaneously. If you have noticed faint horizontal white lines across your nails and a lunula that seems smaller than it once was, those two findings together are not a coincidence. They are the same problem speaking twice. If this has been useful so far, I want you to do one thing before we continue. Hit the like button. It takes 1 second and it genuinely determines whether this reaches someone else who needs it tonight. A 2018 study in clinical nutrition found that hypoalbuminemia in adults over 65 was independently associated with a 3-fold increase in cardiovascular mortality over a 5-year follow-up period. The detail that makes this finding particularly striking is what the researchers observed about the patients in the study. The majority had no formal malnutrition diagnosis at the time of enrollment. Their body weight appeared adequate. They did not look malnourished in any conventional sense, but their protein stores were severely depleted, and their cardiovascular systems were already bearing the cost. A patient I will call Constance came to see me at 71. She was not underweight. She ate regularly. But she had been living alone for several years. Her appetite had quietly declined, and her diet had shifted gradually toward foods that were easy to prepare but low in protein. Her lunula had nearly vanished across all fingers. A blood panel showed albumin well below threshold associated with adequate cardiovascular protection. We addressed the deficiency systematically with nutritional support. The cardiovascular strain was caught at a stage where intervention made a real difference. Constance told me afterward that she had assumed the changes in her nails were simply part of getting older. They were not. They were her body asking for something specific that it was not receiving. The next two conditions are the ones I want you to pay closest attention to. The fourth is peripheral artery disease, PAD, and chronic microvascular insufficiency. The nail matrix capillaries are among the smallest blood vessels in the entire body, and because of their size, they are among the first structures to be undersupplied when systemic arterial circulation is compromised by atherosclerosis. As PAD progresses and arterial delivery to the fingers decreases, the matrix receives less oxygen and fewer nutrients per unit of time. Cell division slows, the lunula recedes, and the change happens so gradually that it registers as nothing in particular until someone knows precisely what to look for. The toenails, which receive even less arterial flow in peripheral artery disease, typically show the more advanced picture: thickening, discoloration, extremely slow growth, and complete loss of the lunula across all toes. But careful examination of the fingernails in early to moderate PAD reveals the same process beginning. The lunula receding on the thumb, the border blurring on the index finger, the change arriving so slowly that it reads as nothing in particular until someone knows exactly what to look for and looks deliberately. What makes peripheral artery disease at this stage so significant is what it reveals about the rest of the arterial system. PBD does not develop in isolation. It is a local expression of systemic atherosclerosis, the same process narrowing the coronary arteries and the vessels supplying the brain. Data from the REACH registry, one of the largest international studies of atherosclerotic disease burden, found that PAD at the severity that produces visible nail matrix changes carries a 2 to 4-fold elevated risk of heart attack and stroke. That is not a minor statistical footnote. It is a major signal. And most patients at this stage have received no cardiovascular risk assessment specifically connected to their nail findings, because the connection is almost never explained in a standard clinical encounter. The nails were recording the arterial compromise. Nobody had translated the recording. A patient I will call Bernard came to see me at 69 for what he described as mild leg fatigue on long walks, something he had been dismissing for over a year as simple deconditioning. During the exam, I noticed the lunula was absent on 3 fingers of each hand and that his toenails had thickened considerably. A vascular workup confirmed moderate peripheral artery disease with systemic atherosclerosis, advanced enough to place him at significantly elevated cardiovascular risk. Bernard had no chest pain, no shortness of breath at rest. His leg fatigue had seemed too minor to mention at previous appointments. His nails had been carrying the story the entire time. Now I want to shift to the 5th condition, and I want you to sit with what I am about to explain, because once you understand the mechanism, it changes how you think about something very ordinary: vitamin B12 deficiency. The reason I ask at the start of these videos whether you take a proton pump inhibitor or metformin is precisely because of what I am about to tell you. B12 is essential for the methylation reactions that regulate DNA synthesis in dividing cells. The nail matrix, with its exceptionally high cell turnover rate, is exquisitely sensitive to B12 depletion. When B12 falls, the matrix cannot sustain the rate of division required to keep the lunula visible. The crescent shrinks. The nails grow more slowly, they become more fragile, and the change happens quietly, over months, in a person who may feel no other obvious symptom at all. Here is what makes this condition different from the others on this list. There are 3 overlapping reasons why adults over 60 become B12 deficient, and they are almost never explained together. The first is that gastric acid production declines naturally with age, and stomach acid is required to cleave B12 from dietary protein before absorption can occur. An older stomach extracts measurably less B12 from the same meal than a younger one would. The second is proton pump inhibitor, medications prescribed for acid reflux and gastric protection that are among the most commonly used drug classes in adults over 60. They suppress acid production further, compounding the age-related decline already underway. The third is metformin, used widely for type 2 diabetes management, which actively blocks B12 absorption in the terminal ileum through a mechanism involving calcium-dependent membrane receptors. A person who is aging, taking a proton pump inhibitor, and managing diabetes with metformin is receiving 3 simultaneous inputs, all reducing B12 absorption. Their nail matrix is often the first tissue to show the result. The cardiovascular connection runs through a molecule called homocysteine. B12 is required for the enzymatic reaction that converts homocysteine to methionine. When B12 is insufficient, that conversion slows and homocysteine accumulates in the bloodstream. Elevated homocysteine is an independent risk factor for coronary artery disease, stroke, deep vein thrombosis, and peripheral vascular disease. A landmark study published in the New England Journal of Medicine in 2002 identified elevated homocysteine as a stronger predictor of cardiovascular events than total cholesterol in certain patient populations. That is not a minor finding. Subsequent research confirmed that B12 supplementation sufficient to normalize homocysteine levels produces measurable reductions in cardiovascular event rates. The B12 was the lever. The homocysteine was the signal. The lunula was the first visible indication that the lever needed attention. A patient I will call Miriam came to see me at 68. She had been on a proton pump inhibitor for 4 years and metformin for 6. She felt reasonably well. Her lunula had become nearly invisible on both thumbs and had blurred significantly on her index fingers. A full panel revealed B12 levels low enough to explain both the nail changes and a homocysteine level that placed her at meaningful cardiovascular risk. We addressed the deficiency directly. Within several months, her homocysteine had normalized. At her follow-up, she mentioned, almost in passing, that her lunula had a visible border again on her thumb for the first time in what she estimated was 2 years. Her nails had been recording the depletion. She had been looking at them every day without knowing how to read what they were telling her. Now let me give you the self-examination detail that separates a clinically meaningful finding from a normal anatomical variation, because this distinction matters. It is entirely normal to have a small or absent lunula on the little finger and sometimes the ring finger in an adult with otherwise healthy circulation. What is not normal and what warrants a direct conversation with your physician is a lunula that was previously visible on your thumb and index finger and has now disappeared or become indistinct. A lunula that has faded across most or all fingers simultaneously. A lunula whose border has become blurred or irregular rather than sharply defined. The change that matters is not the absence alone. It is the change from your own previous baseline, and because that change is slow, happening over months rather than days, most people never register it. They look at the same hands every day and adjust to the new normal without ever realizing that something has shifted. Now let me give you a practical framework for what to do with all of this. Take both hands to a window in good natural daylight. Look at each nail one at a time. Check the base of the thumbnail and index finger on each hand first. Those are your primary reference points. Notice whether the lunula is clearly visible with a sharp border, faintly visible with a blurred border, or absent entirely. Check whether the pattern is consistent across multiple fingers or limited to the little finger only. Look at the nail surface for any horizontal white lines, Merca's lines, because their presence alongside a shrinking lunula reflects the same underlying compromise speaking from 2 directions at once. Write down what you find. This step matters more than most people realize because these changes are slow and human memory is unreliable over months. Take a photograph of both hands in natural light today and save it somewhere you can locate in 6 months. A photograph is honest in a way that memory simply is not. If you find one of these signs, mention it at your next routine appointment. Describe specifically what you observed and when you first noticed it. If you find 2 or more signs together, a fading lunula alongside Merca's lines, or a fading lunula alongside slow nail growth and a history of metformin use, do not wait for your annual checkup. Call your doctor's office this week. You do not need to arrive with a diagnosis. Your job is not to diagnose. Your job is to notice, to document, and to speak up. That is the step most people never take. And it is the step that makes all the difference. That small white crescent has been sitting at the base of your nails your entire life. It has been taking notes every single day, recording how well your matrix is supplied, how efficiently your blood is moving, how adequately your body is being nourished at the cellular level. The only thing that was missing